I Good afternoon to everyone, sir, and I welcome all of you in this online edition of Jaipur Surgical School. So, just to give a brief idea about this surgical school, this is basically an online initiative, and that has been started under the guidance of Professor V.K. Kapoor, head of the Department Surgical Gastroenterology, Mahatma Gandhi Hospital, Jaipur. So basically, the idea is to provide education to the countries, especially from the Middle East, who could not attend the morning sessions. And also, anybody who is interested can log in. We are doing these classes every Friday, 3 to 4 p.m. And the suggestions are welcome, and the topics which the students want can also be shared so that we can incorporate into the program uh, later on. So today we have an eminent speaker who needs no introduction, Professor S.K. Mathur sir, who will be talking on management of acute pancreatitis. And to moderate the session, we have another eminent faculty from PGIM at Chandigarh, Professor T.D. Yadav sir. So I request sir to please kindly moderate this session and start the proceeding. Thank you, sir.
Thank you, Piyush, and very good afternoon to all. And as Piyush has already said, Professor Mathur doesn't need any introduction. But for the people who might be new in that area from abroad, he was the HOD of the Department of Surgical Gastroenterology, KEM Hospital, and after the retirement, he is working in presently in another corporate hospital in Mumbai. And sir, a contribution to the surgical gastroenterology and HPV field is immense. And most important is portal hypertension, where he described this device procedure and the types of the classification of the varices, vasophageal varix, which is all world follows that. So with this, today he is going to talk about the, as you know, there are certain diseases in our HPV surgery, in spite of all the development and evolution, especially of anesthesia intensive care, still there are certain areas where we are still sometimes we are in dilemma and still we don't have sometimes we don't have very clear cut option. So that is the thing sir is going to discuss, and topic for today is acute pancreatitis current concepts or the rationale of management of acute pancreatic necrosis. So obviously, sir will not touch acute pancreatitis without necrosis. So with these words, I request sir to take over now. Dr. Mathur, sir.
Yeah. Good afternoon, everybody. Good afternoon, TD. Thank you for the kind introduction. And at the outset, I'm thankful to Dr. Vinay Kapoor and his team for putting up this program every Friday, which is, I'm sure, will be beneficial for most of the practicing surgeons as well as the students of the basic general surgery and some of the GI surgery also. As I understand, it is meant for the general surgeon more than the GI surgeon. We all know that acute inflammation of the pancreas produces a spectrum of symptoms which may be mild and self-limiting, or it can reflect a severe disease leading to multi-organ failure and death. As per the US studies, it is one of the most common diseases of the GI tract, which leads to, we all know, a tremendous emotional, physical, and financial burden to the patients. The incidence has been increasing by 2 to 5% per year, at least in the United States, and the overall population mortality has remained unchanged, which is around 5 to 9,000 every year. Though we know that advancement in the management of acute pancreatitis over the past decades have been associated with the decreased mortality. So what are the learning objects today? Is how to establish the diagnosis, what are the insight into the pathophysiology and clinical course, the classification and terminology currently used, what are the possible etiologies, how you work with the patient for this, what is the role of imaging, when the timing for it, how do we do the initial assessment and the risk stratification, initial management, like role of antibiotics, fluid balance, nutrition, and then role of ERCP in acute pancreatitis, and finally the surgery. So remember that diagnosis of acute pancreatitis is clinical and lab. And there are three parameters which are looked into, and out of which two should be there. One is the abdominal pain, which should be acute onset, persistent, severe epigastric pain, often radiating to back, chest, or the flank, and accompanied by, if the lab shows rise in the amylase and or lipase more than 3 times of the upper limit of the normal. Or the imaging shows the characteristic finding of the acute pancreatitis, that is pancreatic edema and peripancreatic tissue standing, fat standing. However, remember that this pain, what we are describing, which is typical for the acute pancreatitis, has a differential diagnosis, and we should not forget that. Okay, that is in a peptic ulcer perforation, mesenteric ischemia, Boerhaave syndrome, when the perforation is below the diaphragm, and in severe acute cholecystitis with perforation. So we should keep this thing in mind. Now, regarding the serum amylase and lipase, we know that the amylase rises early in few hours and returns to normal within 3 to 5 days. However, there are cases of acute pancreatitis, particularly when the alcohol-induced and the hypertriglyceridemia-induced, where the amylase may remain normal. So one should remember that. Okay. And because of that, the serum lipase seems to be more reliable, it is more specific, and it remained elevated for the longer period than the amylase. So 3 times of the normal is normal. But remember that sometimes these amylase lipase can be raised more than 3 times of normal in the condition which are not related to the pancreas. And here one should remember that if the pain is not typical and they rise, one should look for the differential diagnosis. And what are the conditions where the amylase can be raised? The abdominal condition, one should remember the acute appendicitis, cholecystitis, bowel obstruction, ischemia, and the peptic ulcer disease. And same holds true for the lipase, again peptic ulcer disease, cholecystitis, liver injuries, intestinal diseases like inflammatory bowel disease, celiac disease, enterocolitis. Okay, so these are the causes where both amylase lipase can be raised. So when there is a doubt about the diagnosis, then one has to rely on the imaging in such situation. Now, what is the pathophysiology? Remember that there are 2 phases of acute pancreatitis. The early phase, within first week of onset, here the severity is related to the organ failure, which is secondary to what is called SIRS, or systemic inflammatory response, which is elicited by the tissue injury and not necessarily to the extent of the necrosis. So, this is in the clinical classification, in the first week, at the onset within first 48 hours, presence of persistent SIRS and or development of the organ failure. Now, how do you define the SIRS? Okay, it is presence of 2 or more of the following criteria for more than 48 hours. That is pulse more than 90 per minute, rectal temperature less than 36 or more than 38, white cell count less than 4,000 or more than 12,000, respiratory rate more than 20 per minute, or PCO2 less than 32 millimeter of mercury. So, now the second phase, which starts after first week of onset. And during this period, either the pancreatitis resolve, which is seen in the edematous pancreatitis without necrosis, or tend to stabilize but not normalize. Or third thing is, it can progress to the necrotizing pancreatitis. And that's where it enters into a more protracted course lasting weeks to months related to the necrotizing process. This mortality in the second phase is usually related to the necrosis becoming infected or developing the complication. While in the first phase, the mortality is related to the SIRS and the hypovolemic shock. So in the second phase, it is the morphological criteria should be applied because the type of treatment is determined mainly by the morphological abnormalities of the peripancreatic or pancreatic region and the presence or absence of any local complications. So based on this new concept in the pathophysiology, there is a revision of the classifications, which is a clinical classification, and the morphological, that is image-based classification. Currently, the acute pancreatitis is classified into 3 types. Mild acute pancreatitis, when there is no organ failure, no local or systemic, complications. Moderately severe acute pancreatitis, where there transient organ failure which resolves within 48 hours, and or local or systemic complication without persistent organ failure. That is basically the presence of the pancreatic necrosis. And the severe acute pancreatitis is the one where there is organ failure which persists beyond 48 hours, which may involve single or multiple organ failure with or without local complication like infected pancreatic necrosis. Now, how do you define the organ failure? So it's very clinical definition. Top, that is systolic blood pressure less than 90 millimeter of mercury, pulmonary insufficiency, PO2 less than 60 millimeter of mercury, renal failure, creatinine more than 2 milligram per deciliter after doing the rehydration, and or get GI bleeding that is more than 500 ml in 24 hours. Now there is another score which is used, which is modified Marshall score. I won't go into detail, which is again a clinical based on the basically the hypertension, pulmonary insufficiency, and the renal failure. So this is very simple way to define when you say the patient is in the organ failure. Now, morphological classification is more related to the structural changes in the pancreas as documented by the CT scan. So if in the interstitial edematous pancreatitis, which is usually associated with the mild acute pancreatitis, there on CT there is diffuse or localized enlargement of the pancreas and normal homogeneous enhancement of the pancreatic parenchyma. That means there is no necrosis, it is only the swelling of the pancreas. There will be peripancreatic fat standing plus minus fluid collection. On the other hand, in the necrotizing pancreatitis, which can be pancreatic or peripancreatic, there is an area of the pancreas which is not enhancing. And I'll just show you the example with the CECT. This is the example of the edematous pancreas, and there is some fat standing in the surrounding area. So this is classical interstitial pancreatitis. On the other hand, here you can see the areas of the pancreas which are non-enhancing, apart from the peripancreatic tissue fat standing. So this is a case of pancreatic necrosis. Now, how do you classify this fluid collection which accompany the acute pancreatitis? Up to 4 weeks, that is first to 4 weeks after the onset of pancreatitis, acute peripancreatic fluid collection, which usually following the interstitial pancreatitis. That means which can be sterile or infective. So here there is no necrosis involved. On the other hand, if there is a pancreatic necrosis associated with there is a fluid collection, either in the pancreatic or peripancreatic region, it is called the post-necrotic pancreatic fluid collection or PNPFC, or this is EPFC. Now both can be sterile to begin with and can get infected over the period of time. So this is the example CT which is showing the peripancreatic fluid collection. You can see this here which are marked around this associated with the interstitial pancreatitis. And this is a classical example of the necrosis of the pancreas associated with the multiple fluid collections. Now, when these collections last beyond 4 weeks, then their definition changes. So, if it is associated with the APFC, that is acute pancreatic fluid collections, in the interstitial pancreatitis, after 4 weeks, if it gets walled off, well circumscribed, usually round or oval, homogeneous fluid, without any necrosis, this is called pancreatic pseudocyst. And this is the example. You can see this about in the stomach here. Indeed, the fluid amylase, the collection of the fluid within the cyst is usually rich in the amylase and lipid. Now, this can be sterile and they can get infected. On the other hand, if the fluid collection persists or the necrosis persists beyond 4 weeks after the onset of pancreatitis, then it is labeled as the walled off pancreatic necrosis or WOPN, which can again be sterile or can be infected. It can remain asymptomatic or may cause pain or may cause a mechanical obstruction of the duodenum or the bile duct. So this is the example of WOPN. You can see this large collection, mottled appearance, and usually now to differentiate whether it is fluid versus necrosis, MR is better than the CT scan. That one should remember. Now, what happens to this necrosis? Less than 1 week, solid and non-enhanced on CT scan. Over 4 weeks, it may get liquefied, become semi-solid, non-homogeneous. There can be complete resorption of the liquefaction and complete resolution of the necrosis, which may take weeks or even months. It may take about even up to 6 months for it to get completely disappear. On the other hand, there can be incomplete reabsorption and persistence of the liquefaction necrosis as the area of walled off pancreatic necrosis, which when becomes symptomatic requires the intervention. Now, what is the role of imaging in acute pancreatitis? So we have got sonography, CECT, MRI, MRCP, endosono. So sonography is not very good investigation modality as far as acute pancreatitis is concerned. Yes, it can show the pancreatic edema and the peripancreatic some fat standing, but in the obese patient, we may not get all that information. It is good for documenting if there is a gallstone, which can be associated with the attack of the pancreatitis, and also can show if there is ascites or some fluid correction. The CECT is the gold standard. Early overall detection rate of necrosis is more than 90%, which can reach up to 100% by day 4. Okay, and it can very well document the anatomy and the characteristics of the fluid collections. MRI, MRCP is as sensitive as CT scan. Only thing is time consuming. It can be used when the patient has got issue of the renal failure. It can be one-stop investigation because it also delineate the. It can also give the information of the about the biliary tree, but it is more cumbersome to perform in sick patients, and that's why a CCT is preferred over MRI. Now, when should the CT should be done? The recommendations are that early at admission, routine CT should not be performed for purpose of determining severity in acute pancreatitis. This one should remember. Early CT should be done only for patients where there is a doubt about the diagnosis or who fail to improve clinically within first 48 to 72 hours after hospital admission and after resuscitation. Usually, we recommend that the first CT scan should be done by day 5 to 7. By that time, the necrosis starts separating out. A repeat scan is not indicated unless there is a clinical deterioration after initial response or there is lack of improvement after 72 hours of the conservative therapy. That means you are suspecting some complication developing there. Now, second issue is which patient of the acute pancreatitis should be admitted in the ICU? Should all patients have a central line? And what are the goals of maintaining the various parameters like blood pressure, CVP, and urine output? And what will the initial fluid management and how much crystalloid versus colloid? Okay. So the initial assessment, hemodynamic status and risk assessment should be performed to stratify the patient whether he is low risk category or high risk category. So low risk category patient can be admitted in the wards, okay, or non-monitor bed. On the other hand, the patient with the organ failure or severe SIRS, having hemodynamic instability, dehydration, they are the one who should be admitted to the monitor bed, that is the ICU. Remember that there are several scoring systems have been described in the past. Now they have been all given up. The one important thing one should remember, even if the patient has got mild acute pancreatitis, one should not take these patients non-seriously. Rather, keep a close watch and their hydration should be well maintained. Because in first 48 hours, if they are not well managed, they can progress from a mild pancreatitis to the moderate or severe pancreatitis. And what are the risk factors which can be associated with the progress is elevated BUN, that is more than 25 milligram percent, hematocrit more than 44, and the presence of obesity or comorbidities. So, what is the initial management? Recommendations are that moderately aggressive fluid resuscitation of the patient with acute pancreatitis and additional boluses if the patient is hypovolemic. The fluid of choice is lactated ringer over the normal saline or any colloids. Caution should be needed if the patient has got a cardiovascular or renal comorbidity coexisting. One should not fluid overload such patients. And how do you start? Usually, in a patient who has got moderately severe or severe pancreatitis associated with hypovolemia, signs of dehydration, acute renal injury, or poor protective indicators such as BUN more than 25 or hematocrit more than 44. In this, you start with a bolus of 10 to 20 ml per kg in first 1 to 2 hours, followed by 1.5 ml per kilogram per hour in the next 24 to 48 hours. So this is a general way to do it. And this should be done in the early course of the disease. And the volume should be reassessed at frequent intervals within 6 hours of presentation. And the goal should be to decrease the BUN below the 25 milligram per deciliter and hematocrit less than 44%. Okay, and why it is important? If you look at this is a normal pancreas, when pancreatitis happens, the fluid exacerbation to the peritoneum, the increased intravascular fluid loss, decreased intravascular volume, that is hematocrit rises, decreased blood flow to the kidneys, so BUN rises, and that leads to decreased blood flow to the pancreas, and that leads to ischemic injury to the pancreas or the necrotizing pancreatitis. And that's why the fluid resuscitation is very important. Now, the second issue is what investigation should be sent at the beginning? Yes, all patients will have a CBC, LFT, serum alkaline, creatinine, amylase, and lipase. When you should repeat? The amylase lipase doesn't need to be repeated because the persistence of raised amylase lipase or the time they take to come back to normal doesn't decide what is the severity of the disease or the management of the disease. Yes, CBC important. Liver function tests are important because they point towards if the biliary stones are the cause, and if there is persistent abnormal LFT, then one had to look into if then endoscopic intervention is required for relieving the biliary obstruction. Now, CRP and PCTQ, CRP will be raised in most of the inflammatory process. The PCTQ is required only when you want to differentiate whether the patient has got an infected necrosis versus patient that does have just have a SURS. And remember that the patient renal function should be normal to interpret the PCTQ. What about the antibiotic policy? When and which one? And should there be antifungal? Now, role of octreotide. It has been well established that octreotide has no role in management of acute pancreatitis. Okay, it has got a role in management of pancreatic fistula, but not for acute pancreatitis. As far as the antibiotics are concerned, general recommendations are there is no need to use any prophylactic antibiotic, particularly in the mild acute pancreatitis. Antibiotics should not also be used in the sterile pancreatic necrosis. But antibiotics are an important part of treatment in infected necrosis, along with the debridement or necrosectomy. The current recommendations are against any FNAC of the pancreatic necrosis for documentation of the infection. Now, what antibiotics should be used? Antibiotics which penetrate the pancreatic necrosis. Okay. And which are the antibiotics? Usually it is the quinolones, second, third generation cephalosporins are carbapenems. Now, with the use of antibiotics in infected necrosis, there is a possibility in some patients, at least it is documented, 1/3 of the patient may resolve completely and may not require any necrosectomies. Routine administration of antifungal is not recommended for prophylaxis. It is only recommended when the patient has a prolonged course, multiple courses of antibiotics, and then one can add the antifungal drugs. Now, next question is the nutrition support, where the parenteral naturally enteral is preferred, and when the timing of starting enter feeds, one can start as early as possible once the patient's that nausea come down and patient not vomiting. Usually in 48 hours, one can start the enter feed. Oral versus nasogastric versus nasogenital is a debate. It depends on what is the patient tolerance. Usually they don't have appetite, so oral may not be tolerated, but the nasogastric or nasogenital gives the equal type of outcome. So enteral nutrition should be started in moderately severe or severe acute pancreatitis to prevent the infectious complication. Parenteral nutrition should be avoided if the enteral nutrition can be started. Using a nasogastric tube, as I mentioned, is good enough. But if there is a high gastric output, in that case, a nasogenital tube can be placed. Now, coming to the role of ERCP in management of acute pancreatitis for biliary pancreatitis. So, usually in biliary acute pancreatitis, if there is no cholangitis, there is no role of ERCP intervention. Only the medical therapy, that is the antibiotics, are good enough. However, in patient which is complicated by cholangitis, early ERCP, sphincterotomy and drainage has shown to decrease the morbidity and mortality. Now, in patients who do not have cholangitis and are not jaundice, if a CVD stone is suspected, that means there are gallstones and suspect there could be a CVD stone, then investigation choice initially is MRCP or US, and then depending on the finding, the ERCP will be indicated. Usually, diagnostic ERCP is not indicated in acute pancreatitis. Now, what do you do if the cause of the pancreatitis suspected to be the gallstones, not the CVD stone? That means there is no indication for ERCP. The recommendations are that patient with a mild acute biliary pancreatitis should undergo cholecystectomy early, preferably before discharge. However, if the patient has got moderately severe or severe pancreatitis, you have to allow the pancreatitis to evolve before you do the cholecystectomy. Then you don't do the early cholecystectomy. Now, regarding the patient with pancreatitis, what are the usual causes? We know that gallstones are the most common causes, but it is also shown that in absence of gallstone, there can be microacids and sludge, which can also be responsible for the pancreatitis. Next common cause is the alcohol. It depends on the area to area. Somewhere the alcohol may be the major cause and the gallstones may not be the major cause. Now, if these are not the causes, there can be other causes like medications, some drugs. There can be infections, viral infections, and metabolic causes such as hypercalcemia, hyperparathyroidism, hypertriglyceridemia. So there are other causes. If you don't find gallstones or the alcohol as the cause, then one should look for the other causes. And if nothing is found, then only one should label as a idiopathic recurrent pancreatitis. Now, among the biliary causes, apart from the stone disease, remember that there can be anomaly of the biliopancreatic junction and may be responsible for acute pancreatitis. So also the sphincter of Oddi dysfunction has been documented as a cause, but these are rare causes, okay, and should be carefully looked into after ruling out other causes. I won't go into detail because that's a topic by itself. Okay. Now, these are the current recommendations which has come in American Journal of Gastroenterology 2024, which can be a little controversial, but I thought I should mention it.
Suppose it comes to the worst.
After extensive evaluation, many patients with IAP will have no.
उससे हमारे प्रोग्राम पे क्या फर्क पड़ेगा? बैठो बैठो.
प्रोग्राम पे
cornerstone of microhealth is what to do. So their recommendation based on these three studies, one meta-analysis, one RCT, one case-based study, that based on the available evidence, we conclude that following episode of acute pancreatitis with no identifiable cause, patients who are surgical candidate, cholecystectomy should be performed to reduce the risk of recurrent episode of pancreatitis, and they have shown that the risk comes down from 39% to 11%. Now, this is a controversial which can be debated. Now, once we have a pancreatic necrosis, then question comes, should we intervene or not? So is there indication? What should be timing and what should be the approach for intervention? So indication for interventions are either infection necrosis, if the development of the complications like bowel fistulation, if there is a bleed into the necrosis, if there is an organ compression like duodenum, stomach, or the bile duct leading to their obstruction, or if there is symptomatic peripancreatic fluid collection causing discomfort to the patient. So how do you say that the necrosis is infected or the fluid collection is infected? There should be general signs, that is presence of fever, local signs, tenderness in guarding, and persistently raised white cell count. They are indicative of the sepsis. If in a patient who is settling down and you find the development of the fever and leukocytosis, or if there is worsening of the patient on the metabolic parameters and if there is deterioration of the organ failure, one should suspect the sepsis. Okay. Now, as I mentioned that if there is an air seen on CT scan, it is indicative that it is infected pancreatic necrosis. As far as FNAC is concerned, it was being done, but now the current guidelines do not favor the FNAC. It depends on the clinical parameters and the CT finding on which you decide whether it is infected or not. Now, what's the timing for intervention? It says that the recommendations are that delay as much as possible. At least it takes 3 weeks for the necrosis to separate from the parenchyma. So, any intervention should be delayed beyond 4 weeks, because what has been found that if you do the early intervention, the mortality is higher as compared to when you do the delayed intervention. However, if the patient starts deteriorating before 3 weeks, what do you do? Do you operate or not? General consensus, do not operate. What you do is maximize intensive care, fluid replacement, ventilator support, go for the higher antibiotic, and look for other source of sepsis. If all these are ruled out, then and the patient is hypertensive in spite of maximal intensive care, look for if there is abdominal compartment syndrome. That will be indication for intervention. If there is early evidence of infection, the presence of air in the necrosis, or if there is development of complication, these will be situations where we might have to do the early intervention. Now, what are the approaches for the pancreatic necrosectomy? Where we have open necrosectomy and the minimally invasive approach, which includes, I will elaborate them further, the laparoscopic, retroperitoneal, endoscopic, percutaneous, radiological followed by retroperitoneal, and endoscopic or laparoscopic combination. Okay. So remember that open surgical debridement was the gold standard for treatment for infected pancreatic necrosis, and substituting word is to with the was, because this was in 2005, it was still considered the gold standard. 2014 or 24, now after 20 years or 19 years, you can say that perhaps we say, no, it is maybe the gold standard, but not the gold standard. And that is because the development of minimally invasive techniques. Okay. One should know what the open necrosectomy meant was conventional methods. The reoperation rate was almost 33% and mortality on average was 42%. Open and semi-open, using of the mesh, using the zipper. There were high incidence of complications in the form of intestinal necrosis, fistulation, hemorrhage, though the mortality came down. And what was the gold standard for the open was a closed with post-operative lesser sec lavage. And with that, the mortality came down to 12.5%. Now remember, if you are doing the necrosectomy, even the open, no sharp dissection, no use of scissors, it is all blunt dissection with the fingers or the forceps, and gently tease out the necrotic tissue. This is the most important thing. And the second thing is the photograph of one of my own patients when we used to do the open method. Open method, keeping the abdomen open is no more practice. Either you do mesh laparoscopy and one can do the planned or demand re-exploration. So it involves the incision, which is closed here. If feeding is nostomy and multiple drains into the lesser sac and do the close drainage and lavage. Now, as against this, we have got now minimally invasive approach, which include the percutaneous radiological, then laparoscopic, endoscopic, and a combination. So originally, the radiological approach which was described was the percutaneous drainage, CT guided placement of multiple large bore catheters, 28 to 32 F, and high volume irrigation through these catheters for removal of the necrotic tissue. And sometimes this one stone removal baskets were used for removing the necrotic tissue. Now, average of 4 catheter exchange were required, a mean of 70 debridement were required per patient. Success was described as 47 to 100%, that is variable. Now, the approach could be transperitoneal or retroperitoneal. Nowadays, usually it is used as a step-up approach for radiological placement of the drain and then use the endoscopic methods. This is something which published in 1996, simple method of draining the pancreatic abscess by using some drainage, using a large tube and putting another tube through this, and you can irrigate the cavity. Now, endoscopic therapy can be transgastric, transdural, or transpapillary. It depends on where the collection is. Usually, it is transgastric. Tracts is dilated to 15 millimeter. Multiple 10F stents can be pushed. A pancreatic tube is pushed inside for continuous irrigation of the collection and removal of this. Usually, the precondition is late intervention beyond 6 to 7 weeks. The necrosis should be partially liquefied or mainly liquefied, should be well encapsulated. If it is all solid, the endoscopic approach is not usually recommended. Complications can be perforation or bleeding. Nowadays, this endoscopic approach has been further refined, and one does the US guided endoscopic drainage and placement of the lumen opposite metallic stent into the retrogastric collection, and through that one can pass the endoscope basket and remove the necrosum and then place the double pigtail plastic stent through the limb for continuous irrigation. From there, we come to the endoscopic radiological to the surgical, which can be laparoscopic, retroperitoneal laparoscopic, and endoscopic transgastric and percutaneous radiological. Okay. So, laparoscopic approach can be transperitoneal approach. Now, it can be through gastric hepatic omentum, through gastrocolic omentum, and through transverse mesocolon. Or it can be anterior extraserous transperitoneal sinus tract approach, and finally the retroperitoneal approach. Okay. So, how do you decide? I think, according to us, it should be planned according to the CT anatomy where the necrosis is situated, and then you can take the call how to do it. So, for this, you can see this is the necrosis which is situated in the gastrohepatic omentum between the liver and the stomach. In this situation, the approach is through the gastrohepatic omentum. Okay, you don't go through the lesser sac. On the other hand, if it is a lesser sac in relation to the stomach here, you can see this large necrosis, then the approach is through the opening the lesser sac and removing the necrosum. If one has put the pigtail initially, it can be used as a guide to put the trocar into the collection. Now, on the other hand, if the necrosum is basically at the root of the transverse mesocolon, then you can't use the other approach, and there you have to use the transmesocolic approach and do the necrosectomy from there. Now, one of the drawbacks of doing the laparoscopic or retroperitoneal necrosectomy surgical is the development of the post-necrosectomy pancreatic fistula. And to take care of that, if the collection is in relation to the stomach, the current approach is to go to transgastric approach and drain it into the stomach. Something which the endoscopist does, you can do surgically. It's like transgastric necrosis. The other approach is a nephroscopic anterior serous extra serous approach. How do you do it? There is a collection here. You can see there is a gas in this, which is indicative of infection. And we put the two catheters, one anteriorly and one from the laterally, okay, in the retroperitoneum. And then you can dilate the tract with the Amplatz dilator and put the large size tube for irrigation. And here you can see that after the necrosectomy is done completely, you can put the two tubes from there. You can use them for irrigation. You can pass the gastroscope through it to see the inspect the cavity. Now, if the laparoscopic approach is not feasible, then you can use the retroperitoneal approach for the collection, which are retropancreatic primarily, retrocolic, retroduodenal, or pointing in the flanks. Now, this example, you can see this necrosis which is lying in the paracolic gutter in the retrocolic area. We put first the pictal drainage, and followed by using the Amplatz dilators of the nephroscope, we put the nephroscope and did the nephrosectomy. So this is a retroperitoneal nephroscopic necrosectomy. Now, sometimes you are forced to use the combined approach. Like this patient has a large necrosis. Okay, you can see this is going right up to the pelvis. So here, the first was endoscopic transgastric drainage, where the fluid part was removed completely. The abdomen became flat, and then given the entry through the laparoscope and did the necrosectomy. So sometimes you have to use the combined approach. Now, what is the advantage of minimally invasive? When you leave the drains in place, you can use these same drains to pass the endoscope, that is the laparoscope or the nephroscope, to inspect the cavities and do the completion necrosectomy. If any necrosis remains, you can remove it. Okay. And it leaves behind, the recovery is good because there are no big incisions, so the patient developing complications are chances are less. Okay. Now, is there a role for open? Yes. There are situations where the open necrosectomy will be required. Now, these are the results. I won't go through all the things. This is available in the literature that open the chance of mortality was 14%. Reoperation rate was almost 30%, and the post-op complication rate was almost 43%. And that's why they're going to distribute. On the other hand, if you look at the retroperitoneal approach, that is step-up approach, endoscopic approach, or laparoscopic approach, we'll find the mortality is least with the endoscopic and laparoscopic approach. Okay. And this is the famous Penta trial, which was published in 2010. 88 patient, which is step-up approach, which is not exactly it is a minimally invasive, but the incision in the lumbar area is quite large. It is about 5 to 7.5 centimeter. And this shows that minimally invasive step-up approach, as compared to the open necrosectomy, it reduces the rate of composite endpoints. So naturally, minimally invasive approach is preferred over the open approach. Okay. Now, how do you decide? I think it is, again, I'm going back, that is according to the CT anatomy and according to the clinical scenario. If there is associated organ failure, if the patient is intubated, I would prefer a radiological approach, which is the least invasive approach. CT or USG guided placement of the catheter, and then you can upregulate the catheter, dilate the tract, and do that. If there is compartment syndrome, then it requires the open approach, which will involve the mesh laparoscopy. If there is necrosis bowel fistulation, you have to resort to the diversion, which is usually ileostomy, and for that one uses the open approach. If there is necrosis with bleeding, then one has to take the help of the intervention radiologist. If it is pseudoanal bleeding, on the other hand, if it is a venous bleeding, you have to do the packing of that area along with the necrosectomy, which becomes open. Also, it all depends on whether the necrosis is walled off or diffuse, uni or multiloculated, solid, liquid, or mix that will decide whether you can, which approach you can use. Now, limitation of the minimally invasive is compartment syndrome, necrosis with bowel fistulation, and necrosis with bleeding. So if there extensive necrosis like this, when you see in the retropancreatic area in the central part, and there are multiple loculated collection in necrosis involving the head and uncinate process, infracolic retromesenteric extension, this becomes the indication for open necrosectomy. Are there problems after this? Yes, patient can develop enteric fistula, can have a hemorrhage, can have a recurrence, and can develop the pancreatic fistula also. Now, one word about the sterile pancreatic necrosis. Should it be conserved or should be managed? 80% resolve with the intervention. The thing is that if you do the non-operative approach, some of them will go to develop infection. Meta-analysis says that operative versus non-operative management mortality remains the almost same. Whether it should be conserved or necrosectomy should be done. As far as the interstitial, the IAP guidelines are, SPN should be managed, that is, sterile pancreatitis should be managed conservatively. Intervention in selected cases, and indication for intervention will be same as for the necrosis, which is symptomatic. That is persistent progressive organ failure, despite maximum ICU support. Now, I won't go into the Ranson's and Apache score, perhaps development of any of the complications or patients' inability to thrive. The indication for interventions are persistent abdominal pain, gastric outlet obstruction, inability to eat, and persistent weight loss. So, reoperation after necrosectomy, if there are unresolved or recurrent sepsis, undrained or new collection, or progression of the necrosis, or if there is development of the local complications. So again, indication for surgical intervention, as I said, infection, extensive necrosis, organ involvement, and no response to the ICU therapy. Now, this I'm showing, this is the old time picture. Dr. Kapoor will agree that we used to do it open, because we used to call at that time pancreatic abscesses, okay, which was basically infected necrosis. So, management of the severe acute pancreatitis with necrosis is not only time consuming but also expensive. Lengthy ICU stay, ventilating support, multiple intervention, and prolonged hospitalizations are the rule. Careful clinical vigilance, intervention only if indicated, aggressive management and the team approach between the gastroenterologist, surgeon, and the intervention radiologist is the way to manage these patients. Suspected infected pancreatic necrosis, assume infection, use targeted antimicrobial therapy. If clinically unstable, then go for the early surgical intervention. Clinically stable, we can continue with the antibiotics and delay the intervention as far as possible. Thank you very much.
So thank you very much, sir, for the extensive coverage of the different aspects of the pancreatic pancreatic necrosis. And I will just try to emphasize certain points. You have covered all the scores, especially Ranson and all, but bicep for the general population, bicep and modified Glasgow, they are a little bit simpler and which can be managed at every center. That is one. And the procalcitonin level has a very high sensitivity for the start of the infection, and also the sensitivity of the antibiotic, whether you are dealing with it working or not. So should have a low threshold to do procalcitonin. Regarding the fluid management, there is a significant change in the approach. We can say that initially when we were registrar, lots of emphasis on the aggressive fluid management. But nowadays it is very clear that we should have a fluid approach which is targeted. Means you have to have either we measure IBC or CBP, and no need to feel too much, because the chances of edema, bowel edema, and intraabdominal pressure hypertension, so we call it, that is one other component which is part of the pancreatic necrosis, ongoing necrosis, which is very complicated and lots of literature is there about the mortality in a patient who have significant intraabdominal hypertension in the acute pancreatitis. So earlier it was about 20 ml bolus, then you start 3 ml per kg, but it has been found that 10 ml bolus and 1.5 ml per kg body weight per hour is a good way of going for a fluid therapy. And obviously, if urine output dips down and you have lots of fluid here and there getting collected, then probably little bit challenge fluid can be given. But we should be very careful in terms of fluid. Antibiotics, sir has already explained, but one more line that the antibiotics, while selecting antibiotic registrar, should also read which are the antibiotics we are going to concentrate in the pancreas. So, like aminoglycosides and amikacin is a preferred antibiotic in ICU, but aminoglycosides, they don't concentrate in the pancreas, so would be of no rule. The same way, other things always have been covered very extensively, and it is also clear that nowadays minimum invasive has taken over, but there are certain clear-cut indications like if whole of the pancreas is necrosed, sometimes you find, and there is a failure of endoscopic treatment and percutaneous treatment, then one should not hesitate in opening. If there is a bleed in the cavity, so sir talked about second operation, then it is better to open. And in PGI we prefer transmesocholic when we are doing open, and I find transmesocholic you can explore whole lesser sac a little bit more careful, so it avoids lots of dissection in the between the stomach and the colon. So these are the points, and with this I open the things for question. Any comments? Dr. Kapoor, I think, has joined.
Yeah, sorry. I joined very late, so I won't say anything. Piyush is there. Piyush would like. Rajendra is there.
Sir is usually so clear. There's no space for doubts to ask him any question.
No, but anything you would like to add or make a comment?
Yeah, only thing is that mild acute pancreatitis can be a great mimicker, and not doing an imaging at that time. I have burnt my fingers a couple of times. One was a case of hepatic adenoma. It turned out finally, which had bled, and he had classic washboard guarding, raised amylase, raised lipase, and we thought we will get a CT scan done on the third or fourth day. But when we did a CT scan on the third day, it turned out to be a bleeding hepatic adenoma. There were other complications with this patient because he was severely asthmatic, fixed airway obstructive disease. So there's very little we could have done for him. And we referred him to a higher center, but they couldn't do anything either. He passed away. So I would say that the threshold for imaging should be a bit lower than is obvious in the literature.
Yeah. So the thing is that one should be watching for if there are any abnormal signs or symptoms. Okay. And that's what I said, the amylase lipase can be falsely raised more than 3 times of normal in the certain conditions. That means they are mimickers. Okay. And there the history is important. Like the case you described, if there is a bleeding adenoma, that means the hemoglobin must have been low. So in a acute pancreatitis in the beginning, there is no reason for the person to have a low hemoglobin. So that, or the patient must be having pallor. So those are the indicators that, okay, you have to be watchful and then you get the early imaging done. Because there's a doubt, even if the lipase amylase are raised and the pain is there, because all these upper abdominal pathology will give rise to pain in the same area as the pancreatitis. Okay. So if there is any distractor there, then one should do immediately the imaging. Then there is no contraindication involved. And then it should not be restricted to the ultrasound. It should be a proper contrast enhanced CHCT.
I think one more point, sir. If the symptoms are out of proportional to the signs, so in a early acute pancreatitis, you will have very severe pain, which is classical pancreatic type of pain, and you might not have that abdominal signs might not be that that great. Like you find in mesenteric ischemia, Rajendra, is much more difficult to differentiate with acute pancreatitis, and that should have a low threshold. If we are
I
having
agree with you, TD. I
any
agree with you. But
doubt,
but
ischemia,
this disproportionate nature, what you have mentioned, that we have been able to use very well to our advantage.
so these are one more thing that because mesenteric ischemia will benefit from the early intervention. So if you have a minimum doubt, then we should be, and that will be you do analysis of the EBG and all those things, and the duration and the pain, site of the pain and classical pain. There are multiple things we can combine. Uh, I'm not finding, sir. Kapoor, sir, is there anybody to see in the chat box? Any chat? I'm not able to see. Or can we have the chat questions? Because we have 2 minutes more. So, sir, can take over chat.
No, there are no questions in the chat. But the point which Rajendra was making, yeah, that goes without saying that if there is any doubt that there may be a possible surgical cause of the acute abdomen, which includes bleeding, which includes perforation, which includes, say, a ruptured or dissecting aneurysm, then obviously early imaging is warranted. There is no doubt about that.
So nutrition also, I think there is a lots of wrong perception among the people in the periphery about the nutrition. I request everybody that the moment patient is stable, maybe 24 hours, then after that one should try to go for in nutrition, and preferably it is enteral nutrition. So if there is gut is available, let the gut going. That is what he just said. And we should try for pancreatic type of nutrition, like less and more protein also, not more than 1 gram per kg body. So one should not be going for a high protein diet and fat. So these are very important, and always exclude hyperlipidemia as a cause of acute severe pancreatitis. So these are the certain things we have learned, and we have in the literature also. So one should be very careful, and one should always be careful of sentinel bleed after doing necrosectomy. This is also very important. And two more points are very important. If you are doing necrosectomy, you are finding bile in the cavity, then be very careful and try to do a feeding gymnostomy. If you are doing necrosectomy, you are finding any doubt of colonic fistula by smell or anything, then there is a role for covering ileostomy to save the life of patient. So these are the very important points, subtle points which are important to do appropriate management of these sick patients.
So I would like to thank Dr. Mathur for accepting my request and invitation, and I hope to see you, sir, more often in these classes and learn from your experience and your wisdom. I would request that if you could maybe deliver a talk on a non-surgical philosophical matter also, which would be good for young surgeons. And I always say in these classes, the live attendance is very small, but our past experience, and I have told Avinash Tank's group, technical group, to make a chart. All these videos are watched by more than 100 to 200 students and practicing surgeons. So the effort which all the faculty and Piyush are putting in to conduct these classes is not going waste. I think students and practicing surgeons, and many of them are in countries other than India, Nepal, African countries and other countries, they are making use of these presentations. So thank you, sir. Thank you very much. Thank you. Thank you, Piyush. Thank you, TD, for